This is imaging of the triangular fibrocartilage complex. I'm Pat Battaglia at Logan University. A little bit background on imaging of chronic ulnar-sided wrist pain. Ulnar-sided wrist pain can be interrogated commonly in clinic with a few different imaging modalities. Radiographs are helpful in evaluating the bony anatomy, in particular if there has been an old avulsion of the ulnar styloid process, or to see secondary findings of what's known as ulnocarpal impaction. Usually, this is associated with an ulnar positive variance and cystic change in the adjacent lunate or triquetral bone. Ulnocarpal impaction is a common secondary finding of insufficiency and delayed treatment of triangular fibrocartilage complex derangement. Ultrasound imaging is useful throughout the musculoskeletal system to evaluate pathology of tendons and adjacent accessible superficial anatomy. So in the setting of ulnar-sided wrist pain, ultrasound can be helpful for evaluating derangement of the extensor carpi ulnaris tendon. In particular, this encompasses tendinosis, so degenerative change, and surrounding tenosynovitis. MR arthrography, so magnetic resonance arthrography, is most helpful to study this piece of anatomy, the triangular fibrocartilage complex, to determine if there's degeneration with or without tearing of this complex piece of anatomy. When we meet in November, I'll present some ultrasound imaging and CT-based imaging of the TFCC. However, the rest of this lecture will principally emphasize MR arthrography, as it is currently the gold standard for studying the triangular fibrocartilage complex and for diagnosing pathology within that complex. The rest of this presentation will focus on derangement of the TFCC. So first, a little bit of anatomy of the TFCC. This diagram here depicts four distinct components that comprise the triangular fibrocartilage complex. Described as one, here, this is the extensor carpi ulnaris tendon and the tendon sheath and or subsheath. Two is an ulnocarpal ligament spanning here, you can see from ulna to triquetrum and hamate. Three is a piece of fibrocartilage called the meniscal homolog. And then four is a composite of dorsal and volar radio-ulnar ligaments and the triangular fibrocartilage disc, or the disc proper. So classically, the TFC is this piece of anatomy. Item 4, the triangular fibrocartilage disc. The TFCC, the complex, comprises all of this anatomy. Now, in cross-section, this is what is typically seen. So here's a cross-section of the triangular fibrocartilage complex. The dorsal and volar radio-ulnar ligaments, the central disc proper, the superficial extensor carpi ulnaris tendon with its sheath, the meniscal homolog deep to the tendon, and in between the two, an ulnocarpal collateral ligament. So again, all of this anatomy is the triangular fibrocartilage complex. The TFC itself is really just the disc proper, which is one part of this anatomy. Sometimes it's helpful to look at ancillary imaging modalities to really learn the anatomy of some of this complex musculoskeletal structures. Here's a CT arthrogram of the wrist, and I'll remind you we have three distinct components of the wrist joint: the distal radio-ulnar joint, the proximal radiocarpal joint, and the distal radiocarpal joint here. In a typical setting, when contrast is injected into any one compartment, it should stay within that compartment. So this is a coronal CT image of the wrist after contrast has been administered into the proximal and distal radio-ulnar joint. Incidentally, note contrast communicating between the proximal and distal carpal rows here from a full thickness scapholunate ligament tear. However, note the intact triangular fibrocartilage complex right here, spanning from the fovea of the ulna over to the radius. This anatomy is intact. We know this because the contrast, which is this bright stuff here, is not leaking through, collecting in the distal radio-ulnar joint. Compare that to a torn triangular fibrocartilage complex, where you have contrast from the proximal carpal row extending through a tear in the triangular fibrocartilage complex, collecting distally and reposing in the distal radio-ulnar joint. That brings us to the function of the triangular fibrocartilage complex. The principal function of the triangular fibrocartilage complex is to stabilize the distal radial ulnar joint, in particular preventing dorsal dislocation of the ulna. This is some of the early work by Palmer, whose classification we'll see in a minute, is still used today for triangular fibrocartilage complex tears. And Palmer studied the function of the TFCC at various degrees of both pronation and supination, and learned that regardless of pronation or supination, the principal function is to prevent dorsal dislocation of the ulna. As a corollary to that, when there's tearing of the triangular fibrocartilage complex, there's subsequent instability at the distal radial ulnar joint and progressive instability at the ulnar side of the ulnocarpal, or the distal wrist joint rather, or the wrist joint. All right, pathology of the triangular fibrocartilage complex. Again, the classification by Palmer, which has been adapted here, is still widely used today. So if you refer out for imaging of the TFCC, you'll likely get some sort of descriptor back if there is pathology. Broadly, pathology of the TFCC has been separated into traumatic versus degenerative processes. In a traumatic type, it's further subdivided into central, ulnar, radial sided, or a distal tear. Degenerative processes principally revolve around thinning of the articular disc, or the disc proper, with or without subsequent joint derangement. And this is a sequential phenomena that's seen in untreated TFCC pathology. You'll get progressive ulnocarpal impaction in degenerative phenomena of the TFCC. So it's important to recognize these conditions early and refer for prompt intervention to prevent subsequent wrist pathology and derangement. So the Palmer classification, P-A-L-M-E-R, Palmer classification, which has been adapted somewhat here, is still the most widely used for describing pathology of the TFCC, in particular on our MR exams. Now with imaging of the TFCC, MR arthrography is best. Here's a non-contrast MRI of the wrist showing an intact triangular fibrocartilage complex coming from the fovea of the ulna here over to the radius here. Same patient, essentially same location, with a post-contrast MR arthrogram, now more clearly showing degenerative tearing of the mid-substance of the triangular fibrocartilage complex. So MR arthrography has been studied and shown to have near 100% accuracy for TFCC lesions. It's not perfect, but it's the best imaging modality that we have. Now I want to review a few cases of TFCC tear. These come from Radiopedia, and you give the appropriate credit. Seen here. So this is a coronal weighted image, fat suppressed, through the triangular fibrocartilage complex. And I'll just scroll through to give you a flavor for the anatomy. This is the radius over here and the ulna over here. So on the ulnar side, this long black structure here is the extensor carpi ulnaris tendon. Here is the meniscal homologue. In between the two, not well seen here, is the ulnocarpal ligament. And then spanning from the ulna over to the radius is the triangular fibrocartilage complex. And here we have a nice example of complete traumatic tearing of the triangular fibrocartilage complex. There should be no fluid communicating from the proximal carpal row through to the distal radial ulnar joint. So you can see abrupt tearing and truncation of the triangular fibrocartilage complex here. Here's a different patient, different case. I'll give credit. Right here, Dr. Matt Skalski. And this is a T1 post-contrast MR arthrogram of the wrist. And already you can appreciate the sort of stigmata of a tear in the triangular fibrocartilage complex. There's fluid or contrast material extravasating into the distal radial ulnar joint. This contrast is placed in the carpal joint, radiocarpal joint, and it's extravasating through a torn, here's a nice example of the tear right here, abrupt tearing, a torn triangular fibrocartilage complex. As you can appreciate, these coronal imaging sequences are usually the best or highest yield for diagnosing triangular fibrocartilage complex tear. Axial imaging and less so sagittal imaging has some value, but the coronal imaging is where the money's at, so to speak, with these tears. And another example of the tear line right here near the radial attachment of the triangular fibrocartilage complex, with contrast material extravasating into the radial ulnar joint. And one more case. The first two cases were more typical of an acute traumatic event to the TFCC. Here's a case of degenerative tearing of the TFCC. Again, from Radiopedia, we'll give credit. Again, Dr. Matt Skalski. You can appreciate thickening with internal signal changes of the triangular fibrocartilage complex, contrast material extravasating into the distal radial ulnar joint, and probably most importantly, extensive thinning of the radial side of the triangular fibrocartilage complex. There shouldn't be this much thinning or attenuation. This is a degenerative phenomenon that happens over time. With progressive change or progressive thinning of this triangular fibrocartilage complex over near the radial attachment, you'll see secondary thinning of the cartilage on the lunate. Lastly, we need to discuss two common associated findings seen in the setting of chronic triangular fibrocartilage complex derangement. The first is ulnocarpal impaction. Here's a subtle case of ulnocarpal impaction. One, there's an ulnar positive variance. This is usually acquired in the setting of insufficiency and destabilization at the distal radial ulnar joint. And then two, if we look closely, we'll see subchondral cystic change within the lunate and the triquetrum here. This cyst is indicative of chronic impaction at the ulnocarpal joint. So close scrutiny for an ulnar positive variance, again, which is usually acquired secondary to destabilization at the distal radial ulnar joint, and subtle cystic change of both the lunate and the triquetrum on your radiographic studies can be helpful to identify or at least suggest triangular fibrocartilage complex derangement. Another associated finding, in particular in the setting of an acute event, is an ulnar styloid avulsion. Here's a case of an isolated avulsion of the ulnar styloid process. Typically, there's associated derangement of the triangular fibrocartilage complex in this setting. I do want to make note, if you see a radial fracture, up to 60% of radial fractures are associated with an ulnar styloid avulsion. Sometimes the radial fracture, which is not present here, this is a case of isolated avulsion, but sometimes a radial fracture will be more obvious and more attention will be paid to the radial fracture. Always take a close look at the ulnar styloid process. This seems like a relatively innocuous finding. However, this should go on to MRA, looking for TFCC abnormality, always, because oftentimes surgical fixation is required to prevent destabilization at the distal radial ulnar joint and subsequent wrist derangement. So to summarize, number one, triangular fibrocartilage complex derangement is a common cause of chronic ulnar-sided wrist pain. This includes one of the sequelae, ulnocarpal impaction. The anatomy of the triangular fibrocartilage is complex and it's best evaluated with magnetic resonance arthrography, that's direct arthrography. Lastly, associated clinical and imaging findings include ulnar styloid avulsion and ulnocarpal impaction.